Good evening, everyone present here. I am Faraz from IGCP Group. Welcome all the participants on today's webinar. And that is on a very important topic. Without any further delay, let me introduce the topic for today's webinar. As we know that as we are able to see lots of cardiac problem these days in our country, so we have a very important topic. Let me start with discussion with that. Like the topic for today's session is that is troponin elevated now what? A case-based approach to chest pain. So for this topic, we have very eminent speaker, none other than Dr. Ramamurthy Bingi sir, and let me share some of the achievement of sir. Sir has done MBBS, MD in medicine, DM in cardiology, and interventional cardiologist as Bingi's Heart Care and Fertility Center, Bangalore. So by taking not much time, let's hear out some of the important concern measures related to chest pain. Over to you, sir. You can start from here.
Thank you, Faraz. Thank you for the delay at which I made. I hope I will try to compensate for the delay, whatever we did. There was a problem with going on to the line because my MacBook Pro, is a really complicated machine. If it tries to accept only some things like Zoom sometimes, you know. Anyway, with this few remarks, let me go ahead and talk about the troponin. Troponins are a group of enzymes which are present in the structural proteins of the heart. And these are very, very important in the binding of the actin and myosin in the contractility. And these substances are often released to the bloodstream on two aspects. One is whenever there is an injury to the myocardial cell, and more than injury to the myocardial necrosis, that the cell death has happened. And that is how it became a very important investigation in the diagnosis of an entity, what we call as an acute myocardial infarction. In the beginning, we were dependent on three important aspects, and even today, the same three aspects we always look into that. One is the patient should be having a chest pain, very typical of an ischemic chest pain, what we call as an anginal chest pain, lasting for more than 20 minutes of time. Along with that, there should be a progressive evolving changes in the ECG in the form of ST segment elevation and or the appearance of the new Q waves. And the third thing was the enzymes. With the evolution of the science, both the scientific committees, particularly World Health Organization, followed by the European Society, endorsed that the troponins have to be a very important aspect in the diagnosis of acute myocardial infarction. Yes, they are important, but before I focus on these aspects, let me tell you the the troponins as such, when we are doing investigation, the evolution that has taken place over a period of years, you have been listening of so-called troponin C, troponin T, troponin I, and the like. It's a family of troponins. And we in the laboratory try to investigate two important components, that is a troponin T and troponin I. Troponin T has been present in not only cardiac muscle, majority of the component, but is also found in the striated muscle also. And whereas the troponin I is present exclusively in the cardiac muscle. And thus, troponin I appears to be much more sensitive than troponin T in the routine evaluation. Sometimes earlier we used to ask for the laboratory to do both the troponin T and troponin I, but nowadays we try to restrict ourselves to only one substance like troponin I or a troponin T. But there are some other aspects also. There are some laboratories which use only troponin T. There are some who use only troponin I. But over a period of time, a new entity has come up in the laboratory evaluation. That is, we often use the word in front of the troponins called HS troponins, high sensitive troponins. High sensitive troponins, both the components are there, troponin T as well as high sensitive troponin I. These tests are so sensitive with the laboratory wise evaluation, they can detect even a smallest microscopic damage of the myocardium, either in the form of ischemia and or injury. And since they are so sensitive, and there is a controversy whether the myocardial infarction has taken place or not, they are often, dependable to make a definitive diagnosis. And thus, high sensitive troponins, particularly high sensitive troponin I, has become a part and parcel of our diagnosis. Now, let me try to take you one by one, step by step, where we try to do it and how we try to interpret it. When a patient comes with the chest pain, say, for example, having multiple risk factors, has got a typical anginal pain, it is not at all difficult to make a diagnosis that the patient may be having an acute myocardial infarction. But on the other hand, there are some atypical pains, or there are some components of the typical anginal pain are disappeared, they're not there, and he lands up in the casualty. First thing is we ask him to make him lie down, and then we try to do an investigation. The ECG is the first and foremost investigations. Unfortunately, there can be about 5 to 10% of the patients, if they have come too early, the ECG can be normal. In that instances, the troponins come in the way. Often we ask the nurses to take out the sample and send it for the investigation for troponin I, high sensitive troponin I. And there are many more acute myocardial infarctions. As I said already, one is atypical MI. There is a very high suspicion he has presented with the atypical non-anginal type of symptoms like giddiness, excessive perspiration, and the like. And the ECG is also not very diagnostic too early. There may be confounders in the ECG where the ECG is masking, is ECG ST segment changes are masked, as in the case of left bundle branch block, interventricular conduction defects, pre-existing left ventricular hypertrophy, or ST changes that are already existing because of the drugs and electrolyte disturbances. In them, the enzymes become very important in making a diagnosis. So we do fall upon some of these patients, particularly the so-called atypical MIs, to look into the investigation. Now, this is called as one of the investigations that we take is what is called as an troponin I evaluation at the point of contact. The moment the patient comes to the casualty, we try to take a sample and try to find out. Unfortunately, though the test is very, very important in making a diagnosis of a myocardial necrosis, but it is also true that the test enzymes, whatever that necrotic cells are there, when they release into the bloodstream and they become detectable in the bloodstream, it takes a minimum period of 2 to 3 hours, 2 to 3 hours before a diagnosis. So we are making a lot of a delay in making a proper diagnosis. You know that we have what is called the time is muscle. The moment the patient comes, we should try to see that myocardial infarction management is done, initiated as early as possible. This is where we are depending more on ECG, ST changes. So depending on the ST changes, we have what is called as STEMI or non-STEMI. Now, enzymes are there. They do help and confirm the STEMI, but they will not be able to help you in making a treatment, because the moment you recognize a STEMI, you have to insert a thrombolytic therapy, because thrombolytic therapy is the drug of thrombolytic therapy is the treatment of choice, or in places where it is affordable or the facilities are available, we may have to do an primary PCI. So the moment the patient comes, we should initiate it. We have been dictated by the terms. The ECG diagnosis has to be done in 10 minutes. The diagnosis has to be moved. The patient has to be moved within about half an hour or so for a thrombolytic therapy or a PCI and the like. So in this process, the enzymes will not be helpful because they take a minimum of about 2 to 3 hours before they start showing rise. So diagnosis either becoming a dynamic after some time, or at the time if the patient is presented quite late to the hospital, say like 2 to 3 hours after the starting of the chest pain, the diagnosis becomes very easy with the enzymes. But for the decision making of starting or initiating treatment, it is the ST segment changes that we see in the ECG become important. Apart from this therapeutic stratification that is often helpful, ST segment changes, evolving changes, QAs, we all know them. But enzymes are the ultimate. As every scientific body, in fact, European society has tried to divide into type 1 MI, type 2 MI, type 3 MI, type 2. That I am not going to talk about it. It is going to confuse. There is an entity called as non-ST elevation MI, particularly in that the troponins they become very, very important. If you find out the troponins are elevated along with the STT changes, which may not be meeting the criteria, we know we have some criteria. ST segment should be less than 1 millimeter, T inversion should be up to 3 millimeter, something like that. If you don't have that changes, often the enzymes will make a diagnosis easy and initiate a treatment. More than that, the studies over the few years they have indicated that troponin evaluation is helpful in not only recognizing so-called atypical unstable anginas, but they have also given us the knowledge that some group of patients of unstable angina or the non-QMIs, they do respond, and this response can be predicted by the troponin elevations, and thus the troponin becomes very important. For example, we do make a diagnosis, non-ST elevation MI, troponin positive, resting STT change. Like that, we go on giving the diagnosis. But when the troponin elevation is high, our mind becomes diverted to the use of the GP2B3A inhibitors and our low molecular weight heparins, because both of these studies have shown that the benefit of these patients, the benefit for the unstable angina patients is much more with these two anti-platelet drugs and the anticoagulants, particularly these newer anticoagulants. So the prediction of the responsiveness is also possible by looking at in the context of the troponins. More than that, they have done in some studies where the troponins combined with the ischemic chest pain, troponins with the STT changes in combination if they take, the diagnosis becomes much more relevant and much more firm. That is the reason why troponin has to be done. Now, when we do a troponin, just like any other earlier enzymes which we have, like CPK, CPKMB, those tests are not being done these days. We have to here also show that there should be at the point of time, there should be a rise, and that rise should show a trend again in the rise and reaching a peak over a few hours, and then it should start falling. This sort of an rise and a fall, a rise, peaking, and then the fall is the most important in making a diagnosis. And thus, this is very important as far as the dynamic nature of any enzymes are concerned. But as far as the troponin is concerned, in the blood, the troponin start rising by about 2 to 3 hours time of the chest pain. They reach a peak in about 12 to 24 hours time, and they start persisting, falling and persisting for almost up to 10 days. This dynamic nature is important to make a diagnosis because the injury cells or infarcted cells, they do take time to release and then fall off. And this particular thing has to be kept in mind before diagnosis. That it means two things. One is troponin, one single test is not sufficient. There should be two tests, one at the time of admission, another at the time of, say, maybe 12 hours. This time interval is variable from one study to other study, from one laboratory to other study. Usually, we try to take 12 hours and 24 hours. The troponin tests as such are costly. Majority of the laboratories try to take only two tests, one at the time of admission, one at the 12 hours after that. There are some authorities who have been suggesting to do a troponin little early, maybe 3 hours. What is called as they have been using some new terminologies called ruling in and ruling out of acute coronary syndrome or acute myocardial infarction. This I am just going to stress you later on, but overall, the tests have to be repeated to make a diagnosis, whether your response is there or not. More than that, we have also learned when you do a troponin value at the time of admission, say it is about, say, 200, and when you take it at a peak, say after 12 hours, it is about, say, 800. The peak value as well as at the time of admission, both the values, more higher the value from the laboratory, more bad is the prognosis. And hence, even simple values that are available at the time of both the admission as well as the peak troponin values are important to give us the prognostic value of a particular patient. One, troponin value is able to diagnose. Troponin values are able to differentiate between a STEMI and a non-STEMI. Third thing is they can prognosticate. Fourth thing, they can also give us the responsiveness for the newer drugs like GP2B3 inhibitors. Now let us come back again to the troponins again. In the context, they're so sensitive tests. If they're so sensitive tests, is it only myocardial necrosis that is capable of producing the rise in the enzymes? Here is the crux. We have started recognizing many clinical entities where the troponins can become elevated. Then we started putting even injury of myocardial cells other than the necrosis. If it is an ischemic cell and it becomes injured, the injury itself can produce an elevation of these enzymes. Now we are changing our dogmatic approach in saying once we see that the troponin levels are elevated, it means a necrosis to the level point. It also means necrosis and as well as injury. So this is the new concept that has come up. We should understand that there are many clinical conditions where the cells can become injured, just in transient ischemia. It may be a hypertrophy. It may be stretching. It may be inflammation in the form of carditis or something like that, excessive catecholamine, many things can injure the cells. And here also, this has produced a new concept in clinical cardiology, particularly in acute clinical cardiology, injury syndromes, acute cardiac injury syndromes. And again, there also, depending upon the enzymes at admission, rise a peak and then fall off of the peak. We have recognized an acute injury pattern and a chronic injury pattern. It little appears to be a little more than what we can accept. And that only thing is I can say that there, apart from the necrosis of the myocardial cells in a myocardial infarction, either ST elevation or any non-ST elevation, it can be just an injury of the cells that can also make a troponins rise. Here it becomes compounded. That means too sensitive test makes a test a little skeptical to be used as an third definitive diagnostic test for myocardial infarction. So there are many conditions, as I said, so many cardiac conditions. More than that, in an ICU setup, sometimes patient is in shock or patient has got a multi-organ dysfunction, patient has got a mild renal dysfunction, can also produce elevated troponin. We have also understood some physiological variables like female sex, old age, they can also make the troponins rise. So, proponents have to be interpreted in the clinical context of the patient. It should not be interpreted just by laboratory test report is there and this patient has elevated troponin, has got an MI. You cannot brush off like that. Please see the patient in toto and try to interpret the lab reports in that context. Now, there are many laboratories. We have to understand that when you send a sample, the sample has to go to the laboratory and the laboratory has to give us the report. It takes roughly about 2 to 3 hours even in the central laboratory. So that much time we cannot wait. So people have come to the concept of what is called as the point of contact testing. Here, many of us, we have the troponin T being evaluated by simple strip methods. It gives yes or no, and sometimes troponin I is also being evaluated at the point of contact, with the reports are available within 1 hour time. So you can make a decision whether the patient can be pushed to the cath lab or not within the period of 1 hour once the troponins are available. Earlier, it was not possible. So this is another important point you should keep it in mind. There is a laboratory to laboratory variation. As I said, high sensitivity troponins have got some cutoff points. Say normally it is 0 to somewhere about 14. Some laboratories say 0 to 17. Some laboratories say whatever it is, the scientific bodies are recommending 95% and above the value of the topmost value should be taken for a diagnosis of an acute myocardial infarction. Apart from, as I said earlier, it is the rise, peaking, and falling of the troponins are equally important. Now, there are many clinical conditions where there are mild elevations, as I said, because of the injury, hypertrophy, hypertension, pulmonary embolism, the diseases like aortic dissection. Sometimes it is also because of just an acute left ventricular failure. So many conditions. Even in patients who are having a septicemia, they don't know why the patient is turning around, is not able to make an improvement. They ask the cardiologist whether there is any changes in the ECG, is there any subendocardial MI has taken place. We ask for a troponin. Troponins are often mildly elevated, a false positively elevated. Same thing happens in a renal failure with the chest pain. We don't know that these troponins are suggestive of an MI or not. So, keeping these caveats in mind, we should always try to, in some of these situations, to document the rise and fall of the troponins. And we have also seen many a times this troponins sometimes are of value in carditis, and we have recently recognized this so-called stress cardiomyopathy. We can recognize the rise and fall of these troponins. These are some of the small subtle points as far as the troponins are concerned in acute myocardial infarction. Moderate elevations are seen in unstable anginas, that is in non-QMIs, and severe elevation almost to the 20-fold to 30-fold are seen in acute myocardial infarction. Sometimes you may say when patient has got a positive test at the time of presentation, it says two things, that definitely the MI has been going on for the last 3 hours or more, and it also says a prognosis apart from that. But it also says that in a particular given patient, there may be a prognostication point also. These three important things should be kept in mind. And now we are moving more and more of quantitative tests rather than the qualitative test. As said, cutoff points. And in our hospital laboratory, we use 17 as the cutoff point. Above it's considered as abnormal. And in some of the places, just they do just a qualitative by strip method, but this should be always confirmed by doing a quantitative test. And thus, troponins have become a very important investigations in the management of acute myocardial infarction. If any doubts are there, comments are there, I will accept them. I'm sorry I couldn't show you my slides.
Yes, sir. Like it was a very well explained, sir, from your end, sir. I hope the thing is that like nowadays people try to get knowledge as much as from the social media, Google, but we are very happy to say that like doctors like you are available to help them more. To all the PG students who are in the cardiology field, all the expert doctors who are into the cardiology, they are going to get lots of expertise from doctor like you, sir. It was a wonderful knowledge sharing. It was a extempore session. Being from a busy schedule, also, sir, you took time and explain this topic really well, sir. It's a great honor. Moving forward, sir, we have received some questions, sir. With all your permission, shall we take this question one by
Yes,
one?
go ahead, please, Faras.
Yes, sir. The first question I can see is from Dr. Subramaniam, and he is asking, sir, just a second, sir. It is getting loaded. Yes, sir. The first question is from Dr. is how to interpret an isolated elevated troponin level in a patient with ST elevation or classic ischemic symptoms, sir.
If the patient has the classical symptoms and ST elevation is there, troponins become secondary point. Because once you have taken an ST elevation within the 30 minutes of his presentation, you are supposed to move your cath lab, you are supposed to start thrombolytic therapy and the like. But other than that, if the patient has got not yet made a decision, you are not knowing whether there is a myocardial infarction is there or not in atypical cases where the ST elevations are already not. This sort of a situation often happens in an already old MI or patients having a left bundle branch block or what we call as an MI having occurring in an infarcted area, what we call as the peri-infarct infarct areas. In them, these troponins will be very, very beneficial.
Thank you so much, sir, for sharing your expertise on this question. One feedback I can see from Dr. Isma Ishtiaq, she has written, well explained, and thanks for this amazing extempore video.
Thank you
I
very
hope,
much.
sir, like they have really enjoyed your session, sir. As I can see, there is no more further questions, sir. As there is no more questions, with all your permissions, shall we conclude this session for today, sir?
Thank you very much. Thank you. Thank
Welcome,
you
sir.
for the. I did put you to the inconvenience for us. I'm sorry for that. Thank
No,
you.
sir, not a issue, sir. It happens, sir. It is a technical
Thank,
part, sir. We would
thank.
like to see you in future also with different topics, sir, with presentation and
I
with
know that.
no
Thank
any
you very much. Thank you.
problems, sir.
Okay, bye.
Take care,
Bye.
sir. Have a great